ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. Happy Doctors Day. Very good morning to one and all. The dignitaries on the dais, the chief guest, Dr. Bhupendra Ahoja, President, IRA Central, and delegates. It gives me immense pleasure and great honor for me to welcome you all to today's CME, Recent Advances in Fetal Imaging and Update at MS Ramaya Medical College, Auditorium. On behalf of IRA Karnataka State Chapter and Organizing Committee, Department of Radiodiagnosis, MS Ramaya Medical College, I would like to extend my sincere gratitude to Dr. Bhupendra Ahoja, our Central President, IRA, for offering this CME to IRA Karnataka Chapter.
I say thanks to the organizers, the President of Karnataka IRA, Dr. Sampangi Ramaya, Dr. Mahesh, who is the Secretary, Dr. Narayana, who is, I believe, he is the most scientific backbone of Karnataka, IRA. It's really a pleasure to be here with all of you and giving me this opportunity or the honor to be a chief guest of this occasion.
A dating scan, preferably done by a TVS, with a reliable CRL and an appointment given for the first time anomaly scan at around 13 weeks, will be the best method to catch the patient for a beautiful outcome of this first time anomaly scan. Many a times full bladder will help us because when the uterus is anteverted, which is the case in most of the women, the fetus is in an upright position in the 12 to 13 weeks. When it is in an upright position, most of the things which we are going to demonstrate in the next few minutes cannot be demonstrated. So the first and foremost thing is to fill the bladder, push the uterus down posteriorly, make it horizontal. When the uterus becomes horizontal, the fetus becomes horizontal.
I'm very happy to be here in MS Ramaya because I was one of the faculty earlier. It's like the job should happen here. It's one of the most important part because as the definition goes that it's one in which the concept is implants either outside the uterus or in an abnormal position within the uterus. It can be divided into most tubal, non-tubal, or it can be heterotopic. The most common is the tubal. That's all of you know, almost 98% of it is the tubal, and only in 2 to 5% of it can be heterotopic.
A very good morning to one and all. And I would like to thank the organizers for giving me this opportunity and Dr. Mahesh for allowing me to talk on this podium. So what is aneuploidy? In a layman's term, it's a definition which says that it's a presence of abnormal number of chromosomes. There are two types. One is monosomy, when one of the pair is missing, like example in Turner syndrome. Or trisomy, when there is an extra chromosome for one of the pairs. Wherever is the extra chromosome in the pair, like trisomy 21, which is on the 21 chromosome, as in Downs, 18 Edwards, and 13 Foetal syndrome.
And now I'm here to share with you
the essentials of first trimester fetal echocardiography. The red color Doppler helps you. You immediately see how many inflow tracts. This is what view? For chamber view, and in red, what are you highlighting? You see the two inflow tracts. They are equal to each other. That's the spine. Always orient yourself to the spine. So that is the left ventricular inflow tract, and that's the right ventricular inflow tract. They are parallel to each other, and they are equal. They are parallel to each other. They are equal to each other, and that's about all that we need to see.
What I'd like to ask you is, understand the ABC mnemonic in fetal neural tube defects. What is A? A stands for the arch, B stands for the vertebral body, C stands for the cord, and S stands for the skin. ABCs, friends, this will help you to give you an organized approach to detect most of the neural tube defects, closed or open.
So I'll take you through the second trimester ultrasound markers, and this is the original name of the markers. And of course, markers, as you know, are referred to in situations where we want to look at aneuploidies. And so we'll put the aneuploidies into perspective again. I'll take a minute to tell you what markers are. We'll discuss the perspective of the first trimester markers. We'll take you through the second trimester markers as well. And then, of course, put a bit of non-invasive prenatal testing in perspective, because we, as radiologists, really do need to know where the clinicians are headed and what sort of a plan they have in mind for their patients, and we have to fit ourselves into that. We'll then go into the significance of the individual T2 markers and then discuss the calculations and interpretation.
This I will be more restricted to only the reporting protocols, which are very important on our day-to-day practice. And the few facts which we have to keep in mind, the 1 in 90 pregnancies is the twin pregnancy. The 12% almost is the total perinatal morbidity, and 25% of the twin pregnancies faces the growth restriction. And the incidence of IUTR and perinatal morbidity almost 3 times than the single twin pregnancies. So with this background, the pregnancy becomes very important for us, and how to go step by the in the reporting protocols.
That's a basic concept that we must know, and that is biometry refers to measuring something. And in this situation, it refers to measuring regions of the fetus. And these measurements give us the size of that particular fetal region. And what growth refers to is not what it is at that moment in time, but the change in that size over a period of time, which is the rate of change or the velocity of change over a period of time. And growth is quite different from development. And the word development does not refer to any change in size, it refers to a change in the form or maturity of function.
The incidence of this placental abnormality, especially placenta accreta, what we say is nearly 1 in 500. So it is very common. I am sure you're all going to come across this one in or other. So awareness is the key. So these placental abnormalities are often overlooked. So, and it is very important to recognize this pathology, so that because it has got a potential for maternal and fetal morbidity.
As with my earlier talk, it's always very disturbing to announce bad news to the patient, and so also when you know the mother is expecting babies coming soon and everything is going well, and suddenly we find that there is no cardiac activity, and we call it stillbirth. So stillbirth is a dead baby born after 24 weeks, and it encompasses into the neonatal stage for about 28 days, where it is then called as perinatal mortality. So anything before 24 weeks is not stillbirth, it's intrauterine fetal death, missed abortion, whatever. But after 24 weeks, we call it stillbirth.
We've had Dr. Ashok and Dr. Chandra take us through 2 very vital lectures, and I think my job is 3/4 done. It lays a very good foundation to what we're going to discuss. Now, my task is really cut out and straight. What we're going to do is to first understand what we know. Now, we know that we can differentiate between an appropriate for gestational age fetus versus a small for gestational age fetus. And if it's a small for gestational age fetus, we also know how to distinguish constitutional smallness or low growth profile fetus from the growth restricted fetus.
The splitting occurs after 13 days. It can lead to the conjoint twins. Here you can see the conjoint twin, thoracopagus conjoint twin is there. So, to conclude, friends, in twin pregnancy, the great responsibility on the radiologist. We must do the coronicity, amnosity in the first, whenever the patient comes to in the first trimester. Singleton growth charts or curve charts are utilized for the same in the twin pregnancy. We decide the growth restriction chord, whether it's a concordant or it's a discordant, or if it is ultrasound. Definitely, as we discussed, as compared to singleton pregnancy, twin pregnancy definitely requires more meticulous examination, and what protocol we used is I have just already discussed with you. Thank you very much.
The cleft lip palate varies between 1:500 to 1:1000, so about 0.1%, and it's 13% of all anomalies. So it's a very important factor, more so from the patient's point of view. When the mother comes to know that she's giving birth to a child with cleft lip and cleft palate, all of us would agree that this cosmetic problem is huge. And not only that, there are other problems associated with it. There are other associated anomalies seen in about 20 to 50%, and it's part of huge number of syndromes.
What I will show is some cases which are culled from practice. What I'm going to show you is quote, unquote from reports, some pictures which have made snapshots of this. I did this presentation a couple of years ago perhaps, so these are not fresh cases, nevertheless cases with some carry home message. What is medical negligence? I just bore you with 2 slides where I will go through. Medical negligence, what is medical negligence? In order to establish negligence, the plaintiff must show that there was a duty recognized by law, a breach of that duty in that there was a failure on the part of the physician to meet what was considered to be the standard of care. And that is why I have in different color, the standard of care was not met during the time of treatment.
Our next talk.
Just 1 minute, we have a national anthem. Before that, I would like to thank our national speakers, Dr. Ashok ji, Dr. Kurana ji, and Dr. Chandar, and our own Dr. Ramurthy, who has done an excellent job, and I thank all the 4 of them, and our state speakers, delegates, and our military college principal, chairman, and Department of Radio Diagnosis, and our postgraduates especially, and our staff. I wholeheartedly thank one and all. Thank you. Before that, there are 2 mementos to be given to the chairpersons, that is Dr. Nagaraj and Dr. Raghavendra Bhatt, and then we'll have the national anthem, then we'll conclude. Thank you.